Soon to be joining us is Dr. Jennifer Wilson, who trained in internal medicine and respirology at UBC and started with the lung transplant program at Vancouver General Hospital in the early 2000s, when the program was quite small. After a period away practicing general respirology in the Eastern Fraser Valley, she returned to the lung transplant group in 2021. And she was very welcome. I've sat with Dr. Wilson, and she's just a terrific person and medical professional. She has a particular interest in the health system improvement and recently took over as head of respirology division at Vancouver General Hospital. Please help me welcome Dr. Jennifer Wilson.
Thank you, Darcy. It's great to be here, and a big thanks to Fran for the invitation. Nobody can say no to Fran. And as well, thanks to BC Lung for sponsoring this. They do great work. I'd like as well to thank Suzanne and Rick for sharing their journeys. It's very, very powerful to hear stories from patients and caregivers. So thank you. I have no conflict of interest to share today. I don't get any industry's funding, and there is no particular funding for transplanting patients. On the right, I realize I do have a little conflict of interest between what I like to do outside my work and my work. I love my job, but I had the great privilege this summer of rafting down the Tatshenshini River in the Yukon and northern BC. It was fantastic. Just an outline of the talk today. I'd like to give a brief overview of the transplant program in BC and share some statistics from our program. Touch on when should we start to think about transplant when we have pulmonary fibrosis, and what does the process look like? What happens when you go on the list? What happens then? What does that look like? How do you get matched to lungs? And then a little bit about the surgery and the aftermath. Painting it with a pretty broad brush. I'm happy to take questions after, and I'm planning to be here for the panel at the end of the day as well if we don't get to all the questions. This is a team. So the lung transplant team is based at Vancouver General Hospital, and the lung transplant clinic is in the Diamond Center, which is just across the street. So it's not just doctors in the transplant team. This is the main group of my respirology colleagues here. There's 6 of us transplant respirologists, 2 thoracic surgeons who are in the background on the screen here, but also a team that comprised of dietitians. We have 2 social workers. We have a psychologist and pharmacists who are with specific expertise in lung transplant. And we all work very closely together, both before transplant in the workup process and after. These are the latest statistics from the BC transplant program going up to 2022. I'll just draw your attention to the top screen. You can see that through from the program's initiation in the 90s through 2000s, we were quite a small program, doing anywhere from 10 to 15 transplants per year. But over the last 5 to 10 years, the program has boomed. We are now doing the range of 55 and on track for over 60 this year, which puts us in the range of one of the larger programs in North America, which we're very proud of. The reason for the increase in transplants is many reasons. We have an increased donor pool available, and that's largely through a lot of work from BC Transplant in terms of recognizing donors in hospitals and enabling community hospitals and more remote hospitals to identify donors and bring them forward for transplant, and increasing awareness of the community of the importance of speaking to their families and acknowledging that they would like to be donors in the case that comes up. The bottom screen just shows the type of transplants we do. The top screen, the majority of the transplants we do are double lung transplants, so 2 lungs. In the earlier time, we did a lot of single lung transplants. That was partly driven by lack of donors. So we were, you can live a decent life with a transplant with just one lung. We do know that overall, generally people do better with bilateral lung transplants. So most of our transplants now are double lungs. Just a word about donors. So the majority of donors are people who've had a catastrophic brain injury and are determined to be brain dead. So there is no brain activity. They're being sustained on life support. So hearts are still beating, blood is still circulating, but if we were to stop that, they would die because there's no brain activity, the brain and the body would not breathe. Over the last 10 years or so, we have also started to use what we call donation after cardiac death. So these are patients who've suffered a cardiac incident or a very severe life-threatening injury, so that they aren't technically brain dead, but that they would not survive with the withdrawal of life support, and they have a brain injury to the extent that they would not be awake at the time. And that is a smaller component of donors in our program. I'm just going to skip over these slides briefly. To summarize, most of our transplants are in an age group of over 60 here. Largely, probably a slight preponderance of men over women. And that's primarily driven by the fact that a lot of the diseases that we transplant for pulmonary fibrosis and COPD do tend to have a slight predominance of men. This is we're largely white. But we do have indigenous and other races. This reflects mostly the population of BC, but also the population who accesses medical care. These three pies are referrals, activations, and transplant. And I'd just like to draw your attention to the dark green slice of the pie, and that's patients with pulmonary fibrosis for a variety of types. So you can see that the majority of transplants we do are for pulmonary fibrosis. And if anything, the size of the pie, has increased in the last 5 years. Because we rarely now are transplanting for cystic fibrosis. So cystic fibrosis is a genetic disease. It's unrelated to pulmonary fibrosis. And we're very fortunate that there's a new drug available for cystic fibrosis patients that's extremely effective. So they're not coming forward for transplant at the moment, which is fantastic for that population. So you've got pulmonary fibrosis. When should we start to think about transplant? This is sort of in general when we should start to think about transplant is when there's a pretty high likelihood that you've got a less than 50% chance of living 2 years. Well, how do we know that? We don't have a crystal ball. We use lung function testing, as Dr. Marinescu had outlined. We look at how rapidly the disease is changing. And we know from studies is how long people are expected to live in general at a given set of lung function values. We also want to make sure that people are well enough to survive a lung transplant. So they want to have a pretty good chance that you're going to live for at least 90 days to get through the surgery. And then we also want you to be robust enough, both physically and in terms of support from your family and community, that you're going to do well and thrive for about 5 years afterwards. So again, it's not an exact science at all. So specifically looking at pulmonary fibrosis, again, we turn to the numbers. So this is recommendations from the International Society of Heart-Lung Transplant, is when to consider referring somebody with pulmonary fibrosis to transplant. For UIP, your idiopathic fibrosis, it's at the time of diagnosis. So if you get a label of pulmonary fibrosis, even if it's early on, start raising the topic of transplant. We are happy to see people early and kind of watch and wait along with your referring respirologist to see how things go, because we would way rather see you early than late. For all the other types of fibrosis, again, there's general guidelines for lung function testing. So if your FVC, that volume is under 80%, or your perfusing capacity, so how well the lungs are moving oxygen, is under 40%, it's time to start thinking that whether transplant might be an option. And there are criteria if it's progressing over time, or if you need any oxygen, either at rest or with exertion, time to start thinking about transplant. Now, I'm saying this as a transplant doctor. Transplant's not for everybody, and there are other paths to take. If your respirologist is unsure how to refer, you can find a referral form on the BC Transplant website, or they can just give a call to the transplant program. I'm more than happy to advise on how to do that. So the road to transplant starts with a referral, and as I mentioned, early referral is best. We like to have lots of time for you to go through the testing and meet our team and see if it's the right time. And if it's not the right time, then we can wait along with you. Once you've been referred, we make a decision as to whether to sort of say, no, transplant's not an option, or we have time to wait. But if it looks like it's the right time, we'll move ahead with the evaluation for transplant. I'll talk a little bit more about that in the next slide. And then if you go through the evaluation and it seems like you're a good candidate, then you go on the list to wait for a transplant. You're active on the list. And then when a set of organs becomes available that's matched to you, then a transplant will go ahead, and we'll talk about that process. You heard a little bit about roads earlier today, roads of pulmonary fibrosis assessment. So the road to transplant is not a straightforward road either. It's full of trees and roadblocks. When we're looking at whether someone's a good candidate for transplant, we want to sort of look at the big picture, not just the lung disease. So you need to be pretty robust. Surgery is huge, the recovery is huge, and you're coming into a big surgery already deconditioned because of your lung disease. One of the big parts with the testing is to see if there are any medical reasons that transplant would be a bad idea. We want to make sure you've got enough support from family or friends who can be with you, bring you to tests, because sometimes transplant goes great, and sometimes it's a rocky road. So you need to have people who are there for you, who can help you take your medications. And of all of the sort of things we evaluate, this is one of the harder ones to evaluate, and one of the things that can be, if you don't have the support, we see things going wrong rapidly. We want to make sure you have adequate nutrition and you're neither too thin or too overweight. And we want to get a good sense of where your lung disease is at. Is it too early? Is it the right time? Or is it, has the window closed? Is it too late? So going on the list. So if we've determined that it's the right time to think about transplant, we do all your medical workup, you meet all the members of the team, we sit together after that's all done and present your case and go through everybody's opinion. And if we are all sort of say, yeah, we don't see any barriers to transplant, and you say, I'm okay to go ahead with it, we'll put you on the list. And it actually is a list. It's about 2 or 3 pages long. It's divided by blood type. There's usually about 30 to 40 people on the list at any given time. The average wait time to get a transplant at the moment is in the range of 6 to 12 months, but it's a very broad range. So I've had people go on the list and get transplanted the next week, like see them, send them home to the Gulf Island they live on, and then bring them back the next day. That's uncommon, but it can happen. Some people wait a long time on the list. So people who are at a disadvantage are often women, because they're small, can be smaller. So it's harder to find lungs that match in size. And sometimes it's harder to make matches because of specific issues. Donor lungs are matched. Blood type is the first thing. So your blood group A or O. We match for size, and then we do, over the last 10 years, we've started to match more specifically for HLA antibodies, and I'll talk a little bit about that. The basics, your genetic makeup determines what markers are on your cells to say that that you're unique. And we also measure antibodies, because some people have more likely to have circulating antibodies against other types of HLA markers, particularly if you have connective tissue disease, you're more likely to have those antibodies. All donor lungs have to meet a criteria of quality. We're often asked about overdose donors. All lungs have to be adequately oxygenated. We see CT scans. We get detailed reports from the donor team in the communities. And sometimes you will hear about exceptional distribution. So we don't know everything about every donor. They're very carefully screened, but sometimes there's details we're not aware of, and then that will be disclosed to you at the time. Just a word about HLA antibodies. There had to be a science slide in here somewhere. So we all have markers on our cell surface that help your immune system decide what's you and what's not you. And if you have circulating antibodies against people, sort of other typical antigens in the sort of common population, you're more likely to have rejection of your lungs. So we measure this quite carefully. So what's it like to get the call when you're on the list? I know we've got some transplant patients in here. I can't imagine what that feels like when the phone goes off. Generally, the transplant team, have about a 48 to 72 hour window where we become aware that there's a donor that's available. The donor is getting worked up, and if you're on the wait list, you'll get a call usually about 24 hours before transplant, sometimes 48 hours. That gives us time to bring you to the hospital, do some sort of preliminary screening, chest x-rays, start some medications, etc. Usually waiting overnight for a transplant that's going ahead the next day. Sometimes the donor becomes unstable and the lungs become unusual, and that's a dry run. So we send you back home again. That does happen, unfortunately. A little bit about the surgery. So I'm not a surgeon. We do, the surgical approach is called a clamshell thoracotomy. So a big incision across the top of your chest. They open the ribs up so that you can expose both lungs, and the heart in the middle, they open up the pericardium. Lungs are done in a sequential way. They'll do first the right or the left, and then the other side. And it's really pretty simple surgery. You just got to attach the airway, the artery, and the vein. So, the surgeons get a lot of glory for this, but really, it's 3 attachments on each side. One gain we've made in the last 10 years is if patients, often people, as you can understand, are extremely sick at the time of transplant, they've got life-threatening disease. Sometimes they become unstable, and the anesthetist cannot maintain them safely breathing on the one lung while they replace the first lung. And then you can go on what's called ECMO, which is basically a bypass that does the oxygenation of the blood. And this incision allows for placement of the big cannulas or tubes that help, it's sort of like dialysis, clean the blood of carbon dioxide or replace oxygen. Don't worry about dying on the table with a transplant, and that it's very, very, very uncommon. We can get you through the surgery. This is just an example of the ECMO circuit. So when you've had your transplant, you wake up in the intensive care unit. This is not a person here. This is a hinged plastic dummy. It's hard to prepare people for what it's like to be in an ICU. I think it's hard for families. It's quite shocking, I think, to see a loved one supported on tubes and with drains coming out and whatnot. If things go very smoothly, you're in the ICU for about 3 days. And as soon as you're able to breathe on your own, then we'll get you upstairs to the ward. And an average stay, again, if things are going really well, you're in there for about 3 weeks while you get moving, get the chest tubes out, and then you go home to live nearby for a few months locally. Transplant's an unpredictable business, though, so there can be many complications that would lead to you having a longer ICU stay or a longer stay on the ward. And just the last note is after you're out of the hospital, after your transplant, you're stuck with the transplant clinic forever. So initially you'll see us quite frequently during the first few months. And then we sort of stretch out the leash as you get better and more independent. We'll see you quite regularly through the first year because that's when the most sort of complications happen with transplant. And then after that, we'll see you every 3 to 4 months. Forever. So you're not done with us. Looking at survival after transplant, if you look here, it's about the 5 years. We call that the median survival. So if we look at everybody who's had a transplant, the median survival at 5 years is about 70%. And that compares very favorably with the rest of Canada in the blue line. And if we compare international statistics, we're also very similar or better. Why? Generally speaking, lungs don't survive as well as other organ transplants. So hearts, livers, kidneys have a longer graft survival. And that's partly because the lungs are extremely susceptible both to infection and to rejection. So if you think we breathe air, all air goes into the lungs and all the blood in the body goes through the lungs. So very, very fragile organs comparatively and a little bit harder to keep going. We have patients in the clinic who are 20 years out after transplant and doing great. And we've had patients who've had nothing but troubles after transplant. And this is a slide I borrowed from my colleague, Dr. Levy. We go into transplant. We want to give you lungs to help you live your life, to give you quality of life and help you live longer than you would with your fibrosis or your other lung disease. But it's not a perfect solution. Lung transplant comes with a lot of complications and a lot of problems. Some people do well and some people do not. It's expensive, it's hard on families, and it's unpredictable. We do not have a crystal ball. And with that, that's this Garvey, who's one of our transplants. I think he's probably approaching 15 to 20 years out now. He had cystic fibrosis, lives up on the Gulf Coast. And I think I'll stop there and leave it for questions.
When it comes to transplant for a woman, the clamshell incision, is that done above or below the breast?
Excellent question. So it's changed in the last 5 years or so. So it used to be below the breasts, but that created some problems for healing and care of the incision. So it does go above the breast. It's not a super pretty scar.
I had a question regarding your statement about the average survival being 70% of 5+ years. So is there consideration given? Is it common? Is it uncommon for a second transplant to be considered if the first one has essentially wore out?
Good question. So we do think about second transplants if the first one has worn out. What we do know from the literature is that second transplants aren't as good as first transplants. The surgery's harder, and often the process that caused the lungs to fail in the first transplant can often recur even quicker in the second transplant. It's still early days in terms of measuring the things that contribute to that. We do every year, we will do a couple, probably 1 or 2 retransplants. You have to be pretty fit. You go through the whole process of workup again, and able to undergo it again. So we do consider it, and it's possible. Okay. Thank you.